Good morning, all of the participants, and welcome to guest lecturing promoting patient safety in Singapore. The Honorable Dean of Erlangga University, Dr. Santi Martin, Dr. Amkes, all represented. The Honorable Speaker for today's guest lecture, Professor Tan Kok Hian. The Honorable all lecturers in the Department of Health Policy and Administrations of Public Health Faculty at Erlangga University. The Honorable Misters and Mrs. from the Center of Patient Safety Research, and all of the participants whom I respect. First of all, let us give thanks to the presence of God Almighty. Because of His blessing, we can gather in this Zoom meeting for today's guest lecture. Ladies and gentlemen, this event was held in collaborations between the Health Policy and Administrations of Public Health Faculty at Erlangga University, the Center of Patient Safety Research, and Institute for Patient Safety and Quality, Duke NUS Medical School. Ladies and gentlemen, let me introduce myself. My name is Afina Wisesa, an undergraduate student in the Department of Health Policy and Administrations as a Master of Ceremony who will guide the activities of today's guest lecture. We were going to the main activities of today's guest lecture, which will be taken over by our moderator as a guide, Dr. Anissa Aditya Asabimetsky, the Health Policy and Administrations postgraduate students of Public Health Faculty. To Dr. Anissa, time is yours.
Thank you, Mbak Fina. Ladies and gentlemen, good morning. My name is Anissa, a Health Policy and Administration postgraduate student, and I'm honored to serve as the moderator for this seminar. I want to acknowledge the presence of our faculty members, respected lecturers, and all the dedicated individuals who have joined us. It is my great pleasure to welcome you all to this seminar on promoting patient safety in Singapore. Today, we have the privilege of having with us an expert in the field, Professor Tan Kok Hian, MD, BS, MBA, MRCOG, MMed, FAMS, FRCOG, PPA from Singapore. Prof. Tan is the Group Director and Senior Associate Dean, SingHealth Duke NUS Institute for Patient Safety and Quality, which was set up to enhance patient safety with the aim of target zero harm, and serves as advisor to KK Women's and Children's Hospital Patient Safety and Risk Council. He is a senior consultant maternal fetal medicine specialist in the maternal fetal medicine department and is head of perinatal audit and epidemiology in KK Hospital. He is conferred the Benjamin Henry Sears Professorship by Duke NUS for his outstanding contributions in the field of obstetrics and gynecology since 2019. Professor Tan is also a member of the Singapore MOH National Performance Steering Committee and initiated the SingHealth Patient Advocacy Network in 2017 and leads the academic medicine enhancing performance, improving care SingHealth. He is also a chief editor of the Journal of Patient Safety and Healthcare Quality and member of the expert group on patient safety for WHO. He is actively involved in the WHO Global Patient Safety Action Plan 2021 up to 2030 and initiated the Global Action for Leadership and Learning Organizations on Patient Safety since 2021. Today, as we are going to engage in fruitful discussions and knowledge sharing sessions, I encourage you all to actively participate, share your experiences, and contribute your insights during the seminar. Ladies and gentlemen, please join me in extending a warm welcome to Professor Tan. We eagerly look forward to his enlightening presentation, which will contribute to our collective understanding and efforts in promoting patient safety. Without further ado, we welcome Professor Tan to start the lecture. Thank you.
Yeah, thank you, Anissa, for your kind words. I will start to share my screen. Yeah, right. So, can you all see my screen? So, first, I'd like to thank the Dean, as well as Dr. Inge, for the invitation to your Department of Health Policy and Administration, the Faculty of Public Health, University Star Erlangga Surabaya, for being able to give this talk. And indeed, honor and privilege to be able to share with you how we promote patient safety in Singapore. So my scope for this 1 hour talk would be on this, right? Firstly, I will tell you what is patient safety and why patient safety. Secondly, I will tell you about Singapore healthcare, and I'll point you to an event that really turned us around for our Singapore healthcare cluster, SingHealth. Then I'll take you through something about the system and culture for promoting patient safety, of which leadership and learning is very important. I will emphasize two key cultures. One is the relating to the just culture and psychological safety and mindset. And we're also promoting patient partnership culture. And finally, I will summarize it using the Global Action for Patient Safety, various strategies as a way to end off how we can approach patient safety around the world. So I hope this is okay with all of you. Right. First, what is patient safety and why patient safety? I think all of us need to know patient safety. You're working in the healthcare or healthcare-related industry or universities, right? Healthcare is now a new discipline. Patient safety is a new discipline in healthcare. So it's a discipline in healthcare professions that applies safety science methods towards the goal of achieving a trustworthy system. It is also a discipline that deals with the evolving complexity in healthcare system. And according to WHO, it's a framework of organized activities that create the cultures, the processes, the procedures, the behaviors, technologies, and environment in healthcare that will reduce risk, reduce the occurrence of avoidable harm, make error less likely, and when it occurs, to reduce its impact. So WHO has defined healthcare quality, of which one of them is actually safety, which is avoiding harm to people for whom the care is intended. As you know, the quality has various parameters, of which safety is the most important. The other qualities are effectiveness, people-centeredness, is it timely, is it equitable, and is it efficient? The WHO has actually sort of summarized it to add one more thing, that is the integration, and integration across the levels and providers so that we can have the full range of healthcare services properly coordinated and delivered throughout the whole of life course of a patient's life. So if you want to talk about patient safety, you have to know these two publications, which actually started the patient safety movement. One is this publication, To Err is Human, the other is Crossing the Quality Chasm. So the publication in 1999, To Err is Human, actually sets out the why is there a need for patient safety, because they were referring to the alarming rates of adverse incidents and errors that occurs all over the world. In the 2001 publication, it actually tells us that we need to redesign our healthcare system to reduce these errors. And therein lies the 6 or 7 qualities of the quality domain, which I mentioned just now. So as I mentioned, very importantly, is that the rate of adverse outcome is actually very high, ranging from 10 to 20% in most of the study. Right. So if you have this studies here, for example, in Singapore, our National Adverse Event Study in 2004 was 9.2% of the admissions. And that leads to about over 2,000 deaths in association with identified adverse event. And that costs about Singapore dollars 143 millions, right? Similarly, you can look at in Canada, Colorado, and Utah, and even in the NHS itself. So it's around about 10%. on the average, and about half of this are preventable, right? So adverse incident, 3 to 10%, serious disability, 7 to 40%, preventable about 40%, and it costs in billions. So this is one of the studies that's estimated some time ago. The World Health Organization, in looking at the global action for patient safety, has also looked at these statistics, right? So 1 in 300 have been harmed while accessing healthcare, compared to 1 in a million chance of being harmed while traveling by plane. About up to 50% of patient harm events can be avoided through strategies, simple, effective mitigation strategies. In high-income countries, 1 in 10 suffer, while in the low, middle income, 1 in 4 suffer from accessing the healthcare, suffer harm from accessing healthcare. So in Singapore, maybe it's 10%, but in developing countries, many of them are actually higher, right? And patient harm is among the top 10 causes of death. In fact, it's number 3 or number 4 around the world. And it carries a lot of burden, especially the lower and middle country. So that's why we need to talk about patient safety. As I mentioned before, medical mistakes is actually number 3. So you can be a specialist in heart disease, you can be a specialist in cancer, right? Cardiologists, oncologists. But I think there needs to be people who are expert in looking at medical mistakes and how we can actually diagnose them, manage them, treat them, prevent them itself. And that's why you have this specialty of patient safety. According to Dr. Tedros recently, he said that if it's not safe, then it's not care. So basically, care has to be safe. If it's not safe, it is not care. So that's a very important message that goes about. From my perspective, right, I always think that among all the domains of the quality, or the 6 or 7 domains of quality, patient safety is probably the predominant, and it subsumes the rest. Because if it's poor quality care, it is not safe. And if it's not safe, it's not care, as mentioned earlier. And one of the concepts that comes out of the mindset that after this lecture, I hope you all may have certain mindset change. And one is to look at the fact that we should try to target zero harm. We try to reduce it to almost zero. It's an aspiration that all of us needs to have if we are studying into this specialty. So to me, it's about making healthcare safe, safer, and safest for patients. So how do we do that? To make healthcare safe, we need to look at the ways to reduce errors of care and harmful care. To make healthcare safer, that is the additional step, right? We need to improve suboptimal care. So cares are lots of them. We need to make optimal. We need to use evidence-based guidelines and protocol consistently. And to make it the healthcare safest, we need to be able to promote safe care and delivery, implementation of care with sharing and dissemination of the best practices. So in other words, actually patient safety is not just about trying to prevent errors, but it's to make healthcare the best. And if healthcare is the best, it's actually the safest, and there would be minimal adverse events. Okay, now I come back to the aspect about Singapore, right? To tell you about Singapore. Singapore itself, we have 3 public healthcare clusters. Some of you maybe have been to Singapore. So we have NUHS, which is from the National University Healthcare System. Then you have the National Healthcare Group, of which Tan Tock Seng Hospital is a flagship hospital. Then SingHealth, which I come from, is the largest public healthcare cluster, and of which Singapore General Hospital is the flagship hospital. I come from the KK Women's and Children Hospital, which is part of SingHealth, and we partner with the Duke NUS Medical School. So I am a faculty of the Duke NUS Medical School, a professor in the medical school, but I also have adjunct appointments as professors in the other two clusters. We also have an active private sector healthcare system. But in general, what we do in public healthcare system, we set the standard for the private healthcare clusters. So in SingHealth, just to maybe introduce again, our largest number are the nursing, followed by the admin and auxiliary, allied health, and medical staff. So we have a total of over 33,000 staff, right? That's quite large for a cluster. And we have the full continuum of care for healthcare. So we have primary care, secondary care, tertiary care, quaternary care, we have community care, and we are introducing home care as well, with the help of the community hospitals. And of course, it's very important in a care system, you need to have good financial and IT support, as well as education. And of course, education and research is important as well. So I now bring you to a very serious event that occurs in 2015 that actually changed the way we look at patient safety in SingHealth and also in Singapore. There was a serious infectious disease outbreak in the Singapore General Hospital, our flagship hospital, as I mentioned. And as you can see here over the screen, right, there are, I think, 22 people were infected. There were 4 people who died related to the Hep C infectious outbreak. And the minister have to appoint an independent committee to review the outbreak, and the minister have to apologize for that. And the implementation committee points up to lapses, right? Patient safety lapses, infection control lapses at the Singapore General Hospital. And this shook us to the very core, because Singapore General Hospital is our flagship hospital, technically one of the best hospitals in the world. And such an incident happens, we were actually quite shocked by that. So this became a turning point for us in our SingHealth DNS academic healthcare system. What went wrong? What are the lessons learned? How do we proceed? How can we prevent harm from ever happening again? So there was a lot of thought goes to what we should do and how we should proceed on, and the way we think, the same way that we do things should not be allowed to go on anymore. We cannot be business as usual again. Of course, we look at, when the incident happens, usually we will do a process mapping to identify the failed processes. We do a root cause analysis, and then to find out the processes involved in the failure. And we look at 2 important factors, the human factors and the system factors behind that, right? Whether they, in fact, do contribute to that. So we did that quite a fair bit, right? And of course, this is published. This event was widely so-called. There was a lot of write-ups in the media, a lot of publicity towards this, and it's adverse publicity for us. And it was stated that infection prevention lapses were the key factors in the Hep C outbreak. At that time, the CEO of SGH also apologized for the outbreak, and we lost the trust of Singaporeans, and we are determined to regain the trust of our citizens. And at the same time, we look at how we should make patient safety and well-being as the highest priority. I was actually appointed to follow up with the report implementation, and I also tasked to lead the SingHealth Infection Control Audit Task Force to conduct cross-institutional audits to reinforce the standard of infection control practice. So this is the recommendations that we actually look at. We accepted the findings, We met up with all the affected patients. We have transparency, that the way we do is open disclosure. We do open disclosure. We initiate a cross-institute. We ask all the institutions to cross-institute so that we have external from another institution coming in to look at it. And we have a report implementation committee, of which I'm chairing. And again here, the aspect is that our mindset should be about targeting zero harm for the patients. Okay, so there's some of the things that I will not go into detail, but some of the things that we've done is we look at the workflow, we look at how our control program can be enhanced, we look at single-use activity, single-dose injections rather than multiple use. We enhance communication. We look at contaminated surveys, because the report says there was a lot of places where they see that were blood spots. So we actually look at how we can clean, make our hospital the cleanest ever, right? All the blood stains and blood spots should not be seen in the hospital setting itself. Should be cleaned properly and disinfected. And then we look at how, because there was a delay in notification, look at how we can bring that to speak up, to be able to notify that as well. So these are the things that we do. We form various committees, basically the SingHealth Infection Control Audit Task Force, the SingHealth Report Implementation Committee. We form work groups to look at environment hygiene, look at education and training, and the surveillance systems proactively. We look at refresher course for infection control. These are our response towards that. And as I mentioned before, we want to make it a learning system. Basically, that I was chairing this audit, and we have the hand hygiene compliance and environmental hygiene compliance by various groups. And while they're auditing, they also share best practices. And we look at all the reports and all the learnings, all the non-compliance, we look at it and we report it up the system and see how we can best be able to maintain the best hand hygiene compliance and the best environmental hygiene that we can have. So we become part of we thought of this concept. Another concept is to be a learning system. We learn and we be able to make it such that it will be the best practice system for that. So another thing I want to share with you is that when we implement things, it can be divided into various categories: weak implementation, intermediately strong implementation, or very strong implementation. Because weak implementation, you can do it, but somehow or other it doesn't stay for long. For example, we give warning labels. We ask people to do double check. We do training. We supervise more and with uneducated. These are there to help the staff to be able to do that. But if it's not sustained, then it becomes a problem. We rather prefer intermediate or strong system. Intermediate is that, for example, you perhaps enhance the documentation and communication better. You change to a better device itself. You train with simulation so they can better remain there. But of course, the best would be actually looking at how we can sustain it, to have some kind of engineering control force function, and also leadership and culture change. So we begin to look at maybe our system, we are doing some part of this, but we aren't able to have strong leadership support, and we don't have the so-called culture change that we want to be able to push it through, with a target zero harm mindset, with a learning system mindset. Maybe we should invest in these particular areas as well. Okay. Yep. So we do have a system. In fact, this is a very old system since for many years. For example, this is a KK Hospital Quality Improvement Patient Safety Framework. We have a system that we will say, you will detect. There are many ways of detecting it, various forms and various data, hospital incident report form, clinical indicator audit form, patient feedback. Then we analyze them, as mentioned, to root cause analysis, sentinel event review, peer review, and we do have quality improvement program to do the improvement, and then we will do change the check. But however, if you have this system, but if your culture is not supporting it, right? How can the culture be wrong? Maybe your culture is a blame culture. Nobody dares to report anything. There's very few reporting events, and people don't learn from it. There's a culture of blame, and people want to keep things not transparent because they might felt they may be punished for that itself. And we don't engage the patient to come along with us to help us with the system. And the patient is just another person another group of people that we need to tackle with itself. So this would, if we don't invest in this trying to improve this, we will never bring on to the next level. So if we don't look at the culture, even though you have a good system, it will never give you a very optimal kind of outcome. So, which is why we look at culture. I think there are many ways of classifying culture. One that is a Pascal culture. Do you want to be unmindful, reactive culture, or do you want to be a proactive, generative culture? That means basically, if you are generative and proactive, you are genetically wired to produce safety, and we will proactively look at things even before the problem occurs. So it is very important to do that, not to be reactive. Or when something happens, maybe you do something, right? So we want to change the culture. So these are some of the points that usually, if within an organization, if you go into an organization, say you look at whether the organization has this aspect, not just the system, right? You look at about their leadership. Does their leadership proactive, driving the culture? Do they have do they create or is accountable for high degrees of psychological safety and accountability? Do they promote teamwork? Do they promote reliable processes of care? Do they promote fairness, just culture? And do they have a learning mindset, a continuous learning culture? Right? So I would say that a lot of hospitals, if you just leave it as it is, if we don't take active step, this is what happened. And this is what I think also happens within our SingHealth system, maybe a few years ago or a decade ago. The blame culture, the blame culture is actually very, very huge. There's also apathy. People also burn out. They feel they're doing a lot of things, but not meaningful to them. Keep on repeating that, so they get burned out. There's a fear culture of reporting, and they go by the system. They don't dare to, if there's something going to happen, they don't dare to tell to the next level, speak up for it to the next level itself. So what you have, the green thing here, very small, not well developed. Pick up culture, just culture, learning and reporting culture, very small. Team culture, small, and some absentee culture. There's no patient safety culture. So this is very small. What we need is to be able to work on this, right? Work on let's look here, structure, system, shareholders, co-involvement, right? Co-creation, leadership involvement, culture, networks, and all these things. And this is what would be the ideal situation, right? The ideal situation is that we reduce the counter cultures, blame culture, apathy culture, liability fear culture, paternalistic culture, all reduce it to a minimum. And we promote the culture that we want for having good patient safety. We want to have a good patient safety and quality ecosystem where the staff find it joyful to work, where they have a strong patient safety culture mindset, a learning culture, improvement mindset. So all these cultures is sort of over here. So I just look at trust culture, just culture, reporting culture, learning culture, system thinking culture, improvement culture, patient partnership culture, joyful workplace culture, team and support culture, resilience culture. So, which is why we are now very focusing on improving the culture within our healthcare system. So it's not just about improving the system, but trying to uplift our culture so that our culture will support the system and the system will support the culture. right? To cut it down into just very simple step is that to get to the zero harm mindset, you need to have leadership commitment, engage interested, plan policies at all levels. So leadership at all levels, not just the top leadership, but various levels as well. We need to invest a lot in safety culture building, right? We need the leadership to be engaged at all levels to promote patient safety commitment. We need to motivate them. We have patient safety awards, so we now have a lot of encouragement for people to move towards patient safety in terms of award, incentive, and all that. And of course, we will need to measure, track, and use quality improvement to be able to achieve the task of moving the needle of patient safety. So this is another example of, at the end of the day, what does it mean, right? This is from JCI, which we also adopted. Basically, at the top, what we want is target zero harm, safe, high reliable care. So another concept that comes out is high reliability. High reliability care with target zero harm, with a zero harm mindset. And across this, as you can see here, leadership commitment. You can see the leadership commitment and a safety culture, then a robust process improvement, which I mentioned. Just the three aspects that you need to do: leadership, safety culture, and a robust process improvement in order to be able to achieve high reliability care that is safe, right? So in fact, I used to go around the whole cluster, but then they put me in the bus here. You can see here. I'm actually in the picture in this bus here, saying target zero harm is our promise to put patient safety above all else. So what do you mean by target zero harm? It's not just about zero harm event, zero preventable adverse event. It's about zero falls, zero complication of care, zero infection. And also at a high level, zero missed opportunity, zero overuse, zero medication error, zero unaffordable care. Care must be affordable. If in Singapore, care is not free, but it's affordable. If a person is poor, it can go into our subsidized healthcare system, and it really cannot. And of course they will co-pay a certain amount, let's say 20% of it. And even if they cannot pay the 20% payment, what we do is that we put them to a means test to say that they are really broke, really poor. Then we have our MediSave and the MediFund will come and help to pay for the healthcare system, because we do not want the care to be abused by rich people, right? Because sometimes, or they can afford it, they should be able to co-pay that itself. So that is our, so we want to ensure that care is given to those who are needed and is affordable. So one of the things that we done at that time when it happens was that we want to improve culture is to launch this Institute for Patient Safety and Quality to be able to champion the culture of patient safety. This was launched in 2017 by Victor Dow, who was a former chancellor, but now the president of the National Academy of Medicine, USA, and Eugene Washington, who was the chancellor and still is a chancellor for Duke University. Right. So as you can see, we have two roles here, because our SingHealth Duke NUS Institute for Patient Safety and Quality is actually an academic institute. So that firstly, it's about target zero harm, reduce preventable harm, embed a strong safety culture. The second aspect is relating to academic medicine. In academic medicine, our motto for Duke NUS Medical School is to improve patients' life. So we want to improve patients' outcome, right? So we have retreat to do that, a joint retreat. That's where we went to Malaysia, Johor Bahru. That was in 2017, and an enthusiastic bunch of the senior leaders come together so that then we decided the patient safety and quality plan, looking at various aspects. And one of them is psychological safety and just culture are the key aspect. And also another one is a patient partnership culture. So these are the three cultures that we thought that we wanted to improve to do that. And of course, we will at the same time train ourselves to be competent in quality, as well as to recognize them in staff in the quality. So again, leadership commitment to zero harm is important, is essential. One of the things that is important for leadership commitment is that they must do regular, in fact, like monthly or fortnightly rounds in their institution. Because this leadership rounding is very important to be able to surface out feedbacks about what might contribute to poor quality and poor safety itself. And this now is tracked and monitored at the SingHealth levels. And when they go around, they do the appreciative inquiry approach. Basically, they appreciate staff for what they do. They get the genuine feedback and then thank them for the genuine feedback. Right. So every quarter, I will report to the SingHealth top leadership about various aspects. And the most important aspect is the leadership patient safety walk around and the analysis relating towards that. And of course, we report the serious reporter events, the near misses, and the audits that we are conducting, the healthcare accreditation standard audits, the infection control standards audit, what are the training programs we are doing, and other engagements, basically like safety award, the patient safety index. So this is regularly feedback to the top leadership itself. So now come to the aspect about our training program. So we have to classify into 6 program domain: patient safety improvement science, innovation system, patient-centeredness, clinical governance and risk, and staff and resident care support. And we have it at different levels: foundation level, activity level, professional levels, and champion levels. So we conduct many workshops in these domains and over 1,000 workshop learners per year. Right? We also train our own staff to be faculties, and some of them who have good ideas to be convener, because we believe that contextual learning, contextualized learning by our own people is very effective. We have external vendor, we use some external vendor, but beginning now, actually a lot of our programs for patient safety are actually in-house, developed in-house. Maybe I could say, let's say more than 70% are in-house. We have about 30% are from external vendors, which is also quite important as well. So I will not be going to the details of the workshop details, but just suffice to say that of the 6 domains, we do have a workshop that caters to it. So next time you come to Singapore, you may be involved in some of these projects, and if you are keen, right? We also talk about quality improvement. We go beyond. We felt that we need to do large-scale and sustainable improvement model. And to have that, we need to have leadership involvement, change management, and learning support. So we train a whole group of our staff now to be able to facilitate change management. So that's to bring beyond just a project, but we want to be sustainable at that as well. And a very important thing is the ability to reduce the staff burnout or the consequences for staff burnout. Burnout, as you know, are many factors. It's not just about workload. It's about meaning and purpose, about the safety, about your work environment, about the ability to learn and improve. A staff can be very busy, but you find meaning in the work and find that he can develop, will actually stays in the system, even though the staff is very busy. But if the staff has nothing to do, and it might feel very bored, and if cannot develop, the staff will actually leave, in fact. So we are trying to, there's no magic bullet for it. We are looking at all the domains, to help us to retain staff and to be able to find meaning and joy at work itself. So again, here are some of the programs that we use. For example, Team Choice is about promoting just culture. Team Joy is about promoting physical, joyful, psychological workplace. Team Grace is to improve civility, right? So we want to promote civility and reduce rude behaviors or disruptive behaviors in our environment. Team Speak is to promote speaking up itself. So as I mentioned about some of our culture buildings are basically leadership driven, multi-professional, in the realistic, contextualized, customizable, and we are trying to nudge people towards good cultures itself. And we do it in-house, we can change it itself. So these are some of the characteristics itself. So some of them are like team steps, which we adopt to enhance the team culture. And then we train ourselves from US, from our counterpart in Duke. We became master trainers for 13 of us, and then we spread it throughout. And I team set very good because it shows us what teams can do to work together very well. And these are the characteristics of high-performing teams and some of the things that they need to do. And we practice them. It's not about just understanding it, right? We practice them to briefing, debriefing, structured communication, critical language, and understanding the situation, right? So again, one of the things that we like is for the PROM course, which is a real life at the site itself, practical obstetric multi-professional training, and we find that that's useful. So we adopt this system, which actually originates from UK, the PROM training aid for ONG. Right. So basically, maybe the message is to make your workplace your classroom itself, right? And we ask staff to raise issue with the club. We have synergy board itself for them to raise as well, right? And at the same time, there's a lot of enthusiasm among the staff. Some staff, as you know, we look at our staff. Some staff are very keen and enthusiastic, right? We make them patient safety champions and enablers, QI champion, change management champions, risk champions to be able to do that. And when they are part of it, they feel motivated, and in fact that helps in terms of creating their joy for work as well. So I have a couple of slides about psychological safety, right? Psychological safety is ability to speak without fear of the negative consequences, to be able to feel respected as well. And as you know, if you have a very poor speak up culture, you tend to have poor care because it might lead to certain events. And this has been shown by some research. And in SingHealth, that's why we have this program called TeamSpeak, which we develop in-house, using various very simple things, the 2-channel rule, the CUS word, and to be able to respond respectfully, right? So the words that we said at one level, when you have to be very respectful when you raise the concern. You say, I'm concerned, and if the respondent still doesn't really get the message, or then you say, I'm uncomfortable. And most of the time, by reach this stage, the receiver will say, oh, okay, I understand it is, then they might be able to change the course of what they are doing. But if it's still, doesn't understand, then you can say this is a safety issue. And we say it's safe to be able to say all this. And this is not just a very simple kind of thing, just telling people. We actually practice them in workshops, all the staff at all levels. So they understood this is our common language in SingHealth, right? So 2-channel rule, password, and respond positively. And we actually recognize, and if there are events that happens and they actually turn things around, we actually give them award. SingHealth Family Target Zero Harm Award. We encourage this kind of positive culture behavior, right? We look at our speak out culture. In fact, as you would now, is that more than 75% of our staff are actually trained in that. Staff come and goes, but I think we have quite a lot. And we realized, we did a survey, and our staff are more willing to speak up now, from last time 50-something% to now above 70%. Right. The other thing, of course, is the aspect about staff, right? When staff is involved in an area, there can be a lot of emotional consequences to the staff, right? So we have James research tell us that we need to look at all the aspects and find out what is the cause of it. And frequently, there's human factors involved, right? You can say, okay, we can improve the organization, the environment, the staffing, but there's a lot of things happen because when a human commit errors, there's a lot of psychological consequences. The person might feel guilty, the person might feel that he's been blamed and various aspects, right? And that's why we are also paying attention, a lot of attention to second victim of medical errors, where there's a lot of unhealthy psychological symptoms and behavior that's reported by doctor nurses involved in patient safety investigation. For example, extreme sadness, difficulty concentrating, depression, sleep disturbances. So it is important to be able to have a support culture of not just trying to do your best, but those who are involved, we need to find out how they are and do our best to support them. Okay, because every practitioner sometimes have, I myself make errors, and sometimes I feel psychologically not up to it. But of course, I recover, right? But there's some stuff who never recover. So it's important for them to seek psychological help. And that's why it is important to have this culture, the just culture. The just culture will look at the systems and the people, right? And if it's a system issue or the culture issue, we should try to change it. If it's a people's culture, to say that maybe they tried their best, but because of circumstances, they can't do it. But if it's a deliberate attempt, then we will make the staff accountable. So moving from blame to accountability. So this is a famous chart about just culture model. If it's a human error, we should in fact not discipline the staff. We should console the staff, counsel them, make sure that they are okay. If it's an at-risk behavior by the staff, then we should coach them on how to do less of this and shouldn't be doing this at-risk behavior. If it's a persistent reckless behavior, then we should discipline the staff. And so the algorithm should be able to divide them into these various groups itself. Right? So as I mentioned here, just culture and the culture of trust are pretty important for that, right? Okay, and we do give awards and share talks by people about them, how they are able to go through certain errors and how they will prevent certain errors as well. So again, patient safety culture mindset, first do no harm, target zero harm with just culture, and then we pledge to be a safety advocates to be able to target zero harm itself. And in fact, target zero harm is achievable. Some of our hospitals having very high rates of compliance and also very low or zero rates of adverse events, as you can see over here, thromboembolism, wrong side surgery, and others. It is, and we should need to celebrate success as well. Okay. I still have about 20 minutes, I think. I will now go to another culture that is now getting more and more important. That is about patience. In fact, our SingHealth, our motto, our common purpose is patience is at the heart of all we do, right? Among all the things that we've done. And our GCEO said, what the patients want is actually what we want, right? So there's this movement towards embedding patient advocacy, creating a patient partnership culture, right? I've written recently just that we need to create a patient partnership culture to replace the old paternalistic healthcare culture. And that's critical, right? Because if we do that, then patients can actually help us. If they are involved, they are engaged, they can in fact help us to detect and report near miss and adverse event. They can participate in programs that will educate themselves about safety hazard. They can also take an active role in patient safety and be involved in driving efforts to improve the culture of safety itself. So you can also see that different. Then you have very strong patient support group. If you have this culture, you have many good patient support groups. You will also have person-centered care facilities. All your mindset is that person-centered, patient-centered is our philosophy of care. So this is very important to enhance that. And of course, we will have also groups that relates to patient-partnered care facilities. So in US, they call it the Patient and Family Advisory Council. In SingHealth, we call it the SingHealth Patient Advocacy Network, or SPAN. Right. So quickly, I will just run through several slides of you to tell you the growth and development of SPAN. It started with a small group. I remember that at the time, it was just only a few groups where I asked them for feedback. But then later on, now it grows into more than 50 active patients advocates. And in fact, they have formed themselves, they're autonomous. With a bit of support for us from the Secretariat, they look at membership, education, outreach, and project among themselves. So these are all patients or patient caregivers, right? And in fact, they come together to create the mission, vision, core values, and strategic trust. And their vision is empowered patients at the heart of quality healthcare. So I'll just flash you, I was quite amazed by them actually. They are involved in so many activities, over 100 activities. These are some of the activities, talks, programs, speaking engagement as well. And they even ask us to engage them early so that they can be involved. They create a toolkit for us of how can the staff can be better involved. They actually were involved in seminars, training programs as well for the nurses. They're involved in projects. This is a project to look at how we can better design the care, design so that the wayfinding is better. This one is about safety at the various touch points, and about neurosurgical protective headgear. They're involved in developing that as well. They come up with a plain English glossary. Quite amazed by that. And it's been used by us so that we can better communicate with patients, right? Because we always say ambulant, AMH, advanced care planning, but the patient has no idea what it is, but you tell them in simple terms, you want to move around, care for yourself when they're unable to speak, then it sort of would be a better kind of communication. They are involved in IT as well. They are involved in our patient bedside tablets. In fact, so we are all together in this, because the patient bedside tablet is for the patient. If the patients are not involved in the design, it's a bit awkward because the patient have a patient perspective towards how it should be done, right? They are involved in training as well. So they train future, upcoming patient advocates on how to communicate well, how to tell the best patient story so that it can have a bit of impact. They curate a lot of patients' stories, start a program, Be Kind to Your Healthcare Team itself, right? I think the number of projects there are quite a lot, involving projects, training, speaking engagement, award judging, that. And so now it's about, I think, over 150 projects or so in that. So this is our, and we are very happy to have this patient partnership culture being developed because they're very strong. And these people, they are our patients, our caregivers for the patients, and they are actually a very talented group. So you'll be surprised that your patient can actually help you a lot because they themselves have a lot, and they have, a lot of them are keen to volunteer their work, because when they volunteer, they find meaning for life, because they're helping people and they're helping beyond their own disease that they're caring for or they are suffering from, right? So this is the letter they written to our national newspaper about to stop abuse of healthcare workers and to be kind to them, especially during the COVID environment, right? So patient partnership culture is pretty important. Okay, finally, for the last maybe 15 minutes, I just like to tell you to discuss you with respect to how we can bring this all together, because I was involved in the Global Patient Safety Action Plan, and they have very nice strategies that we can look at to improve our culture and system for patient safety. So this is a Global Patient Safety, which says that we need to strengthen science-based system, and patient safety is a critical element for delivering quality healthcare. That was adopted a resolution in 2019. Yeah. World Health WHA resolution, Assembly Resolution 72.6. Yeah. So just before COVID started, we actually have a meeting. I see none of them are wearing masks. That's in February 2020. And after that, everybody started wearing masks. So basically at that time, we come together to develop the Global Patient Safety Action Plan itself. And this is a Global Patient Safety Action Plan, which is the key is towards eliminating avoidable harm in healthcare. It's basically target zero harm, but they put it as towards eliminating avoidable harm in healthcare. Yeah. So Anissa, is okay? I've still have 10, 15 minutes more, right? Correct. Yeah. Right. So so if you look at this, their vision, mission, and all that, and I was speaking for the healthcare facilities during the launch. There are 7 strategies which I will go through with you on how Singapore has sort of put itself to be able to fine-tune further the patient safety action plan. Right. So as I mentioned, Singapore has 3 healthcare clusters, and in fact, our maternal mortality ratio infant are quite good. Our life expectancy is also quite good, but we use this to further fine-tune our care itself, right? Because this patient safety is a boost for our patient safety culture. We use it to boost our patient safety culture and the reference for all our healthcare clusters to do better, to fine-tune, and to share good practices, and also to help us promote organization learning. So, for example, the first strategy is about policies to eliminate avoidable harm. We have actually fine-tuned our healthcare system such that we continue to maintain legal protection for those involving in learning, right? For some center, let's say serious reporter events, when it's been discussed, we have quality assurance committee, and this quality assurance committee, whatever is discussed there cannot be discovered by law for lawsuit or what. It stays within the quality assurance committee, so there is protection for that. At the same time, I mentioned about we report all our engagement in terms of trying to reduce harm to our leadership, right? So we look at our RCA. So that's really high reliability system in Singapore. We have actually, for the last 1 or 2 years, we have actually moved further. Usually we were accredited by JCI last time, but now we have worked with JCI to do internal Singapore local national accreditation system, where we do it with such a way that we promote leadership, safety, culture, and continuous process. It's no longer a pass or fail, but it's about trying to get at higher level of patient safety. And we have now training. We have trained already some of them, but we're still training a lot of change management experts to be able to bring us forward as well. So this is the aspects relating to target zero harm itself. Clinical process, we look at collaborative. So currently we are doing it with the National Diabetes Collaborative. So we're working ways to improve the clinical processes itself on a massive scale throughout all the clusters together. So we now focus not just on small scale projects, but large scale projects that will help in terms of the clinical processes. For example, diabetes, we do have a lot of leg amputation rate, a lot of admissions, and that we're trying to make sure that the care is optimized so there can be good community care and less admission to the hospital, and there's a less complication from diabetes. I mentioned about patient and family engagement. This is our SingHealth Patient Advocacy Network that I mentioned has been done quite a fair bit. I've shown you about how we move them to be able to do it, to have a strong patient partnership culture. At the same time, I have shown you also that we have a lot of programs that we want to improve the healthcare workers' education skills and safety levels. We even developed a competency stream for patient safety advocates and staff, right? Information research and risk management is very important. So it's important to be able to do the data properly, get the IT properly, get the risk aspect properly. And this has been emphasized in the strategy number 6 itself, because we know that if we learn, we can change things, right? Because don't waste a lesson, build a learning system. So some of the things that happens is, for example, the code system, which we have learned, actually save us a lot of babies' life because we're able to respond very fast. So we established a code green for our learning system. Patient identifications, we have also improved our patient identification so that we reduce, like allergies that we do not know, and then patient died as a result because given the allergic medication, we be able to make sure it's the correct patient we are treating and doing the operation on. Right. So wrong patient site, wrong patient, wrong surgery is that, and that is, we can do this through a simple checklist. And I think Indonesia, you're promoting that as well. And in SingHealth, we have done that, and we are ensuring compliance at a very high level. And of course, very important to have the partnership and the solidarity relating to it. So we created networks to improve patients' care. Even in our community, we ask the neighbors to come together. So it's a neighbors for active living, because a near neighbor is better than a distant relative when it comes to emergency, right? So there's this Chinese saying, 远亲不如近邻. So a near neighbor is a better bet than the distant relative. Okay. And finally, coming together, one of the things that demonstrates Singapore has, I think, suffered a lot from COVID, but we have actually done quite a bit to prevent a lot, even more suffering. We actually managed some of the things quite well, so that we reduce the disruption and the, and the complications as a result of COVID. And one of the things that we come together, we do a all government, all ministry approach, all society, a whole society approach to do that. And these are, and our Prime Minister says that very important to have trust in the healthcare, good patient safety culture, and be able to come together to be able to have the community collaboration and trust for synergy, partnership, and solidarity within COVID. And even our patients gather with us, because our patients cheer us on itself. The media also cheer us on in terms of the public healthcare system. And as long as we are competent, we are committed, and we are transparent. When there was a vaccine error, we are transparent about it. We don't hide it. So there's this very high trust, people coming together, effective public health response, and that makes us relatively able to cope with COVID. Yeah. So these are some of the factors that help us do that, so that we can prepare for the next pandemic. And at the same time, just like this, we have a Gallup program where we share some of our best practices with that, and we also look at their practices, which of them are not so well done, so that we can share. And those who have good practices among the other countries, we encourage them to share with the other countries as well. And finally, we even have now formal programs in terms of patient safety and healthcare quality. We have the Duke NUS graduate certificate, our medical school graduate certificate for patient safety and quality. We have graduate diploma and master degree, where we look at, because patient safety is an interdisciplinary science, we bring together all the science and try to come to something. Because and if you're trained in this, if you go to the hospital, healthcare system, you'll be good at risk management, clinical governance, quality improvement, because everything involves patient safety, right? So this is what we hope to do. And these are some of the skill sets that can be done. But I'm not going into detail about that, and some of our faculties of that as well. So finally, thank you very much. I think I've spoken like almost an hour. If you have any queries, you can send me an email. This is my email. Or you can go to our website here, over here. They may get additional information about what you want to know and how we can help you. So thank you very much. I'm very happy to be able to share with you. I will stop share now. Thank you so much. Yeah. I hope I've done within the time of 1 hour. Yeah.
No, it's on time.
Yeah.
Amazing. It's like 60 minutes short.
Yeah.
So thank you, Professor Tan, for the comprehensive and enlightening presentation. I will try to make a short summary regarding the presentation, just short. So patient safety is a global priority, right? And the global action on patient safety led by WHO seeks to improve patient safety worldwide. Professor Tan also stressed the urgency of ensuring patient safety, considering that unsafe care is the third leading cause of mortality. The ultimate goal is to make healthcare safe and strive for zero harm. The seminar also told us a significant turning point for SingHealth Duke NUS academic health system after a serious outbreak in Singapore. This prompted a critical evaluation of patient safety measures to prevent future incidents. Key actions included process mapping to identify failures and conducting root cause analysis, which revealed that infection prevention lapses were a major factor in the outbreak. Healthcare organizations were encouraged to learn from such incidents and implement robust patient safety protocols. Strong leadership and culture change were identified as effective drivers. To truly enhance patient safety, a comprehensive approach addressing systemic issues is necessary. Creating an ideal patient safety and equality ecosystem involves reducing blame culture, liability, fear, apathy, and burnout culture. Instead, the focus should be on promoting a learning culture, systems thinking, safety culture, and other positive aspects. By uplifting the entire system, healthcare organizations can actually foster a culture that prioritizes patient safety and quality care. This holistic approach encourages learning, collaboration, and open communication, up to psychological support, benefiting both healthcare providers and patients in the pursuit of the highest standards of patient safety. Well, now let's move forward to an interactive session where the audiences can ask the questions and share the thoughts. To ensure an organized discussion, we will begin by accepting 3 questions. And if time permits, we may extend the Q&A session to accommodate additional questions. For the audiences, if you would like to participate in the Q&A session, please use the raise hand feature in the Zoom application, and I will acknowledge you to speak. Alternatively, you can type your question in the chat box. Yeah. Okay, so the first question from Mbak Badriah Putri Janahya.
Okay, thank you for the moderator. Is my voice audible?
Can you please speak louder? Mungkin agak keras sedikit.
Oh, okay. Is it clear enough?
Yeah.
Okay. So thank you for the opportunity. As mentioned before, leadership commitment is fundamental for maintaining and improving the quality of care, especially for the patient safety. And it's also mentioned that the commitment be a factor in sustaining the program of the patient safety. And I also found it really hard based on my experience by joining a lot of organizations and also being a part of the committee for the campus event. So I've been wondering, and I would like to know from your perspective, sir, how do leaders build the commitment? Because we know exactly there is no perfect leaders, but we can be a good one. Thank you.
Is it possible you could repeat for Anissa repeat again, because on my part it's rather soft. The last part, you know, the question, yes.
Okay.
Okay, so
Okay, so the main part of the question is that the important thing for the patient safety is the commitment and also the organization, the culture of organization. What about your perspective regarding the leader to cope with the commitment of the patient safety? Because there's no perfect leader in this world.
oh, yeah. So yes, thanks. I think that's a very important question about the leaders themselves, because you know the leaders might have to cope with all this. There's so many challenges itself, right? So actually, in terms of the leadership, we just need to have probably two things. One is that the priority that's given to patient safety should be as high as the financial or the enrollment of that. So leadership, if you're a healthcare person, you need to have that concept, because sometimes a lot of people doing a lot of other things, but the leadership, patient safety is put at a very low point itself. Secondly, is to have the mindset of patient safety, that you can actually do things, bring things forward, because a lot of leaders think that, well, as long as the system is working, or there's a root cause shows that something happened, we just change the part, and the staff didn't do this, so we just tell the staff to do that. What I mean is that not only putting that as a patient safety priority, but a mindset that they can themselves do that. So one of the things that actually change things around is that the leadership role model, it actually walks the ground. That means basically, so you ask yourself, the leaders, am I going to the ground, let's say every fortnight or every month, even though I'm the very top leadership, to come down to talk to the ground people And when you talk to ground people, there are a couple of things that you need to do. Firstly, you need to tell them that patient safety is the topmost priority for you. They can sense it, right? Secondly, you need to appreciate for what they have done, because they will feel very happy. They feel like, oh, this leader is appreciated. Then you will need to be able to listen to them. What is it? And try to perhaps, after listening, to try to say, discuss with them what they think would be the way to do it. Even if you eventually cannot do what they say, but at least you try your best and you tell them that you have tried. So these are the key, is the key thing. It's not about just, okay, the thing is wrong, I correct the thing, okay, the thing that people do. But you actually coming down, and people, once they have this, they sense that, oh, this leader have very strong involvement in patient safety. So I think, if you think patient safety is important, I will think patient safety is important. If he appreciate us, sure, he's very interested in us also. So you actually show that our leader is interested in us and how to move forward. And he actually attempted to listen to us to see how we can be done at itself. So he gave a feedback. It doesn't matter later on, you can't solve the problem, right? But of course, we hope that among the 100 problems, at least you can solve like more than 50% of it, right? But if even the problem is not solved, at least you show engagement, at least you show that you are with them, at least you motivate them to think of better ideas to do that. So I'm not thinking about like trying to do extra things, to look at something, but just having the mindset and be involved in that. So that might change the culture, because if you believe the culture, because we always role model. If my boss don't think that, let's say, eating Indonesian food is like, so I usually don't like. If my boss likes to take Indonesian food, right, always bring to an Indonesian restaurant, then I'll follow. Then I might develop a taste for it, right, at the same time, right? So it's the boss that shows the role model. I don't know whether I've answered your question.
Is that clear enough, answering your question, or should I try to explain you?
Yeah, it's clear enough. Thank you so much for amazing explanation, sir.
Thank you. Thank you, Badriah. Yeah. Okay, so we have another question here in the chat box, Prof.
The chat box, yes. Can you read out the question to me? Is it what do you
Yes.
think is the weakest chain? Is that question?
Yep.
Yeah. So the question is, what do you think the weakest chain in the healthcare provider that's hardest to improve the patient safety based on your experience at the 2015 Hep C outbreak itself? Yeah. The interesting about this Hep C outbreak, we still do not know what the cause is, because we examine at all areas. We still do not know why so many patients are infected. Obviously, it's an infection lapse, but we could not pinpoint where it started or where it moved. But what we could see was that when they do a check, you look at using torchlight, you could see some of the beds there's some blood stain, not cleaned well. So we thought that basically the environmental hygiene is poor, because there's some blood stains here and there, and things are in a mess, and they were using so-called multiple use of a single syringe, but we couldn't attribute that to that. So in this case, where we cannot find the actual root cause, we look beyond that. It's actually, we look at the culture and the system. Obviously, our infection control system is not strong, because the compliance to environmental hygiene, the hygiene technique is not there. But then we already have classes, we teach people how to do certain, how to inject certain things, how to do it safely. So obviously the culture of good hygiene is not there, right? So of course we could go in and tell people that, okay, we need to do refresher course, we need to do, or to make sure that you are there. That can be done, and that was done actually. But above the level is every down level is the culture of hand hygiene and of general hygiene. It is just not there. And this culture is that they think it will never happen, because yeah, never a bit dirty here and there, a bit blood stain here and there, doesn't matter. I use double user. But once you tell them this is very important, and that's that. We change the culture to a learning culture, what happened, and the understanding culture that this is important. Then it sort of, I think, has never occurred anymore. And usually we have, when we audit the place very clean, itself. So I think is the weakest chain is that while we have the system that does it, but it's difficult to sustain. And difficult to sustain is because the mindset is not there. Because people afterward tend to be, lax, very, very, very relaxed. They don't think, but to us, because this is, if they know that infection is very important in the renal transplant unit and the renal dialysis unit, then they said, no, I should keep on to the absolute hand hygiene. And this is a culture that our ward will aspire to. So to answer your question, the weakest chain is actually, at the end of it, is actually the poor culture. That I think it's also important to be able to do that. So question number 2 is, should I answer question number 2 now? Anything else? Why is psychological safety why psychological safety is characteristic of high performing team? Well, the high performing team, definitely you need to have very high psychological safety, because if, for example, if you have a team of, let's say, a senior doctor and a junior doctor and a nurse, right? If the nurse or the junior doctors found that there's something wrong, right? And that the consultant is doing something that not usually done and shouldn't be done, because they realize that it's just over the dose or shouldn't do that. And both of them know it, right? And both of them whisper to each other that is, but they don't dare to tell the senior person. And then they have to confirm each other, and then timidly tell them. It might be too late, you see. So it is important to that. And we psychological safety means what? It means that even you challenge the person, and the person say, I understand that. I thank you for your concern. Then you go and check. Actually, what you raise is actually incorrect. Actually, what I'm doing is actually correct. Even if the person who raised it is incorrect, the person who is receiving have to thank the person for, say, it doesn't matter. I think you have raised up because you think there was a concern. I appreciate you for that. That is the most important, rather than trying to find out exactly whether the concern that you raised, should not be raised because I'm doing the correct thing. Then you went, hey, next time you don't try to tell it. You cannot do that. Basically, is that the person should have to thank the person for raising up the issue. So we always say that when you talk about speak up, the person who listens is equally important. So we have videos to show how to listen properly and how to listen respectfully, even if the concern raised was not valid after you have found it. Yeah. So address patient with mental disease. Okay. So patient with mental, when we are talking about the whole general population. If patient with mental disorder, then of course we have to treat according to the situation of the patient. See, because some mental patient, if we always think that they are very disruptive, then we should use ways to be able to make sure that the person is not disruptive. Right, it is okay to do certain things, but not to be overly harsh at restraining that particular person itself. Right, I'm not so concerned about patients with mental disorder, because patients with mental, we know they got patients with mental disorder, we know how to. Is that patients sometimes they are okay, but suddenly because their relative is got problem, then they start becoming abusive. And shouted. They're actually okay people, but because of the extreme stress that they've gone through, they suddenly very disrespectful to the care, to the doctors and nurses. In Singapore, we have a sign says that no matter what, we will not tolerate abuse to healthcare staff. So we tell the patient that So we tell them, warn them beforehand. But even then, if the patient is angry, we will always try to maybe give them the benefit of the doubt. But if they really, hit a doctor, then our Singapore law is quite stringent. They will probably be face charges, which sometimes after the judge look at it, maybe because of consequences may, shed a severe penalty, or maybe even say just a warning or something. Is that okay?
Okay, one more question from Sikia Midori.
Yeah, just I answer part of the question. So I suppose you are I say a staff dealing with patients with mental disorder. Whether the Singapore healthcare system address the needs of patients with mental disorder in terms of patient safety. Patient with mental disorders has the separate issues relating to patient safety, because when they have mental disorder, it might be difficult because they can be sometimes disruptive, or sometimes they in those with dementia, right? They may not even know who they are themselves. So when you do patient identification, usually we tag them right away, right? So that we know that these are the patient, because sometimes for a couple of reasons. One is for good patient identification, so you attack for them. Secondly is that sometimes they get lost, they just disappear from the hospital, and we are able to sort of track where they go. So mental disorder, there are many kinds, right? So we will deal with it according, but the basics of patient safety still remain. Have good patient partnership culture, have a just culture for the staff, in terms of looking, and have a learning culture. So if we learn something is not going well with our patient mental disorder, then we learn about it. There's a lot of incidents, for example, like sometimes patients with mental disorder, they have higher risk of suicide, right? So we learn that let's say, unfortunately, if there's a case of suicide, then we have to learn, we have to check if the staff having do a lot of suicide or attempted suicide may not be the staff issue, but maybe some kind of having a better way of system of communicating with the patient itself. So this is very individualized to that. So it's a very broad area to do that. And we do have our mental health institute, and they do look at promoting just not only those with psychosis, but those with neurosis as well. So in Singapore, we're trying to reduce stress for the whole population, and we have meditation and so for staff and for the public as well to do that. So it's a very broad area. Yeah.
Okay, so there are two participants. Maybe these are the last two questions. Yeah. Okay. The last two questions from Midori.
I didn't see it in my, yeah. Can you speak up, because I didn't see it in the chat. Was it in the queue?
Okay, so Midori.
Yeah, so can you speak up? Who's that? Who wants to go first? Or Arya, is it? Or Badriya?
I'm sorry, I cannot open my camera. And then
Oh,
I
okay,
want to say, everyone say thank you for your presentation and very useful information from Professor Tan. And then in the PowerPoint slide, you mentioned earlier about serious infection disease outbreak in Singapore General Hospital 2015. And you respond to the PowerPoint slide about responding to recommendation from an independent review committee. From there,
Yes.
I want to ask, are there any obstacles in its implementation? If there are obstacles, you can describe. Thank you.
Okay, so your question is about the Hep C incident, whether there are any obstacles in the implementation. In fact, I think the implementation was quite clear, that we have infection control lapses, and that we need to deal with the infection control lapses. And the hospital actually appoint a implementation committee, which was chaired by me, to look at it, and we addressed all the complaints. In fact, we went beyond what was recommended. You see, because we actually have number one is that we ensure all the infection control lapses are closed, right? Basically, is that, for example, single use versus multiple use, we will suggest that it should be single use. In terms of environmental high hygiene, we ensure that everything is clean, because one of the main findings was there was a lot of the environment, it seems not to be hygienic, because there's still, and we actually do that. So we actually introduced a whole audit team, right, from the whole cluster to help out with SGH, because SGH is part of a single cluster. So we bring all the 10 or 11 institutions together, and we have a system where we cross audit each other in that. So we went beyond just trying to improve the hygiene of that ward or the 1 or 2 wards to the whole hospital and to the whole cluster. So whatever is being done in SGH, we do it for the other institutions, like from KK, Changi General Hospital, Sengkang Hospital. So our audit extends to the other hospitals as well. So in the case, we actually went beyond that, because we believe that, I think it is important to look, if there's a systemic issue there, then we will need to bring it up to the higher and the cluster level as well. So and then we also do proactively survey. We make sure our IT system is able to surface out cluster easier, because the issue is that, how do you know that there's a cluster is coming out? So we have a cluster base. So we make our IT to be able to do cluster based. And for example, if a lot of doctors suddenly was fall sick, we will be able to tell that, oh, maybe there's a cluster because the doctors and nurses are falling sick in that particular area as well. So we look into and then we organize it at cluster level. We also get at system level. The operations will look at all the aspects. And in fact, now we're beyond. We go into even the kitchen hygiene, sterilization hygiene itself. So there wasn't really any obstacle. The primary reason is that because our leadership at the top level and are committed to make this system and culture change. So in the end, we are able. The obstacle is because trying to organize things. So it takes a bit of time to organize, but there wasn't much of obstacles as I reflect from now itself, because of the very strong leadership commitment by SingHealth and its various institutions. Yeah. So, thanks. Yeah.
Thank you. Well,
Okay, thank you.
Any other questions?
Last question from Mas Arya.
Yeah, from Arya, right? Yeah.
Okay, thanks. Thank you for the opportunity, Professor. I want to ask about you mentioned that we need to move from the blaming culture to actually holding the person responsible. Then I want to ask about how or when the healthcare management making a correction about some unsafe behavior on the employee, is there any borderline between the punitive or blaming the person and actually holding the person accountable for his action? It's more on the technical side, how the healthcare management do it. Thank you.
So sorry, can you repeat your actual question? I mean, I can answer the question, but what exactly do you want is unclear about from what was it? Can you repeat the question again? That just one question. Yeah.
Sorry.
Yeah. Can you repeat your question again? Because I know you're talking about just culture and how we are doing it, right? Is there any thing that you are particularly concerned or not sure about? Yeah.
I'm concerned about the borderline, like when is some action taken is like punitive, or is it just holding the person accountable but not punitive or blaming that person?
Yeah. So this thing so I have to. It's actually a very difficult thing, because our instinct from our our past culture is just to find the person responsible, and then so-called discipline the person. Discipline the person can come in various ways. Some of them may be a reprimand, maybe a note of warning, or sometimes you can go further like a cut in the pay, or sometimes like, suspend the person for some time, or even publicize the person or dismiss the person altogether. So everything must be tailored according to what the so-called gap is, you see. So it's very clear if a person comes in drunk and then committed an error, right? This is something that shouldn't be the outcome. Then in this case, it will be quite serious. It will be like, a serious warning, and that if you do this again, you'll be fired, something like this. Or, but if a person, for example, is involved in a medication error, and then give an incorrect dosage, then we will go kind of algorithm. How did it deliberately do the incorrect dosage? But obviously not, because a lot of healthcare staff wanted to help people. Maybe because the person is. Then we look into the factors. Is it the environment factors? Is it the patient is it the staff factor? Maybe didn't sleep well, or maybe the environment is dark, or maybe it's very busy environment that cause it, or maybe the system is too complicated. You have to do a lot of things and things to do that. In this case, where we find that the staff is just trying its best but commit an error, we actually would help console the staff, but we will look at the system and culture that can actually help itself. But of course, there's another staff that keep on. It's always this staff who make the error. It's a busy environment, but of all the staff, it's always this staff, right? So obviously, this staff is not paying particular attention. So in this case, we won't so-called discipline the staff, but we will counsel the staff that, hey, maybe you should pay a bit attention, and maybe he has some problems that he's concerned about, some family problems or something. And if not, so sometimes, but if you keep on repeating, usually we have some coffee chat with the staff and everything, and if it still doesn't change, and then having found out there's not due, it's just because this person doesn't want to be careful about certain things as compared to their staff, then we will take disciplinary action. The key thing is that if the thing happens, you put yourself in the shoe. Would it happen to you? So you said, if I'm in that particular very busy and everything, will I be a mistake? If I would probably make a mistake, then the staff is blameless. Because I myself could have commit such a mistake. Yeah. So that's it. I hope that answers your question.
Yeah.
Yeah.
It's very clear. Thank you, sir.
Okay. So as we conclude this seminar on promoting patient safety in Singapore, I would like to extend my sincere appreciation to Professor Tan for his presentation and valuable insights, and to all the participants for your active engagement. Before we end the session, I would like to take a moment to extend a warm welcome to our esteemed Dean of the Faculty, Dr. Santi Martini, Magister Kesehatan. Without further ado, please join me in giving one round of applause to welcome our esteemed Dean, Dr. Santi.
Ini suruh ngapain nih Mbak Asam? Saya.
Pembukaan aja.
Ini aja ya, menyapa aja mungkin ya, karena kan sudah dimulai ya. Hello, Prof. Tan, ya. Thank you. I would first of all, I would like to say apologize that I cannot join for the first time. The lecture is delivered by Professor Tan, because I have to attend the invitation from the city mayor of Surabaya, because Faculty of Public Health get appreciation from the mayor for the supporting to create the population with the new, or not the new, the healthy lifestyle.
Healthy lifestyle, okay.
Yes, to break the what we call open defecation free. Yeah.
Right. Okay.
So Surabaya can achieve 100% the population no did open defecation free. Yeah.
Oh,
So,
okay.
there are many elements to support the achievement, and one of the element is the lecturer and the student who have the activities to break the open defecation free in communities in Surabaya. Yeah.
So yeah, thank you.
And
basically,
I would like to say thank you very much for
Yeah.
Prof. Tan
Yeah.
to support our campus to give and share your knowledge and expertise to our student and also to our lecturer. Yeah, because patient safety, I think, is very important. Yeah, for everybody must know about the knowledge. Yeah. Because we are facing with the patient, and we hope that patient come to the hospital, they can discharge from hospital to be healthy. Yeah. Not get any other disease or any other infection, something like that. Yeah. Thank you very much, Prof. Tan. Hopefully we can come to Surabaya, to our campus in person. Because we know Indonesia was already open border. I think Singapore also. Yeah, so we hope that we can meet you in person. And thank you very much also for Bu Inge and also for the team who prepare this lecture, so we can have this meeting as our plan. Yeah. And hopefully we can, you and your team can develop for the next activities with Prof. Tan, yeah, such as joint research or joint publication and anything, yeah, related to education things, yeah. Okay, thank you very much, and also for the student who joined with this lecture. Yeah, I think you get many much lessons, yeah, and I also follow the discussion, yeah. Thank you once again, Prof. Tan.
Thank you so much. Thank you for the, I'm very happy to be able to share and learn with your faculty. And in fact, your faculty has been doing a very good job in Indonesia. I'm very impressed by your faculty and also by Inge, some of the projects. And we hope to be able to learn together and contextualize for our environment. And thank you so much for giving this time to be able to speak to you. Yeah, thank you so much.
Thank you so much also. You're welcome, Prof. Tan. Yeah. Thank you very much for Anissa. Yeah.
Yeah. So, okay, so thank you. I will now leave. Yeah, thank you.
Thank you so much, Professor.
Thank you. Bye.
I'm sorry.
Gimana? Udah
Untuk Clara nggak jadi ya?
Loh, Prof. Tania udah quit ya? Udah leave ya?
Iya, Prof.
Oh,
Sebenarnya mau
mestinya mau ini ada diskusi lagi.
Dokumentasi, Prof.
Oh, dokumentasi. Tapi tadi sudah toh?
Belum, kebetulan.
Oh, di-invite lagi aja Bu Inge. Prof, belum dokumentasi. Ya, please join lagi gitu.
Mungkin karena di sana hampir jam 1 Bu Santi, jadi mungkin ada kegiatan lain. Jadi enggak apa-apa, mungkin kita akhiri.
Oke, nggak apa-apa, wes Mbak Asa.
Jadi sudah bisa ditutup. Ya, sudah bisa ditutup ya kalau gitu. Terima kasih semuanya atas partisipasinya hari ini. Mohon maaf atas segala kekurangan dari saya. Saya tutup. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.